we are here today for Meet the Expert class on hormones and mood. And our experts today will be Professor Rossella Nappi and Professor Andrea Genazzani. And we will have Professor Martin Birkhauser that will be chairing this session. Professor Birkhauser is Professor Emeritus in the University of Bern in Switzerland. He has been head of the Division of Gynecological Endocrinology and Reproductive Medicine at the University of Bern. He is member of the board of the International Academy of Human Reproduction and treasurer of the International Society of Gynecological Endocrinology. He has been a member of the executive committee of the International Menopause Society, where he held the position of treasurer from 2005 to 2008. He is also honorary founding president of the European Menopause and Andropause Society and honorary member of the International Menopause Society, honorary president of the Turkish Menopause Society, and honorary member of several menopause societies in Europe and South America. Our first speaker will be Professor Genazzani, if I well remember, or Professor Nappi. Anyway, Professor Genazzani is a professor of gynecology as well as scientific and medical researcher in many fields, including endocrinology, embryology, and fertility, with numerous publications and books. He is president of the International Society of Gynecological Endocrinology and former president of the International Menopause Society, editor-in-chief of GRAM, Gynecological and Reproductive Endocrinology and Metabolism, and past editor-in-chief of Gynecological Endocrinology. And our last speaker is Professor Rossella Nappi. Professor Nappi is gynecologist, endocrinologist, and sexologist at the Research Center of Reproductive Medicine and Unit of Gynecological Endocrinology and Menopause Department of Obstetrics and Gynecology at the San Matteo Foundation in Pavia, Italy. She is board member of several scientific societies, among them the ISG and the International Menopause Society, as well as author of more of 250 articles on peer-reviewed journals. So I am asking now to our panelists to switch their, to unmute and switch their videos on. And I would ask to Professor Birkhauser to chair this session.
Thank you, Davide. I would like to welcome you as your chairman to this truly important webinar dedicated to the subject mood and hormones. An impact of hormones has been postulated already in the 19th century by Kreppel in Munich. Later, Bleuler, father and son in Zurich consecrated most of their work to the endocrine impact on psychosis and depression. Unfortunately, the mechanical thinking of the 50s and the 60s of the last century dismissed largely this primordial relation. Now we are back again in recognizing the important role of hormones for mood and some diseases like psychosis and depression. We name it today the psychoneuroendocrine axis. The first lecture presented by Professor Rossella Nappi, one of the best specialists in this field worldwide, will teach us the impact of the premenstrual syndrome on mental health. Rossella, please.
Thank you, Martin. Hello to everybody. It's a real pleasure and honor to be here with you today and to share this virtual podium with Andrea, my mentor and friend. And also I'm particularly pleased because you should know that if you go to PubMed, you will see that my first publication back in '91 was really on premenstrual syndrome. So it's a long-lasting love with gynecological endocrinology we are sharing today. And I would like to start with this cartoon I produced several years ago because it summarizes in a very simple way what we intend when we consider neurobehavioral aspects of reproduction. And just to remember to everybody that this strong brain gonads liaison take place since the very beginning of our female project, from genetic and of course epigenetic intrauterine experience, and then of course is modulated by all the reproductive milestone. And PMS MDD is one of the most important aspects of this relationship between sex steroids and the brain, we will see, in a continuum that goes from menarche to menopause and throughout the aging process. Premenstrual disorders include both PMS and PMDD. Let's look essentially at the epidemiology to make clear to everybody that unfortunately we don't have a very clear figures regarding the prevalence of this condition, because according to different studies, and I will try also to explain why it's so difficult to make good research in PMS and PMDD, as you can see here, according to different studies, more or less 3 out of 4 women, 75% suffer from some kind of PMS, and moderate severe symptoms are present, according to the study, between 20 and 40%. PMDD, that is premenstrual dysphoric disorder, we will see in a minute, is present between 3 and 8%. So you see big number, but also highly variable. Why is this is the case? We know for sure that to have premenstrual dysphoric disorder or premenstrual disorder in general, we should demonstrate a temporal relationship between fluctuation of these symptoms that can be physical or psychological, and the phase of the menstrual cycle. And progesterone exposure is essential to develop this symptom. These symptoms should be documented prospectively, and they should be present only during the luteal phase. So you easily understand which is the first challenge, that we really need to follow women for a certain amount of time to demonstrate, maybe by the use of a menstrual cycle calendar, then I will show you, that the symptoms are really related to the luteal phase. But of course, we will see that these symptoms, they manifest a strong clinical heterogeneity. The diagnostic criteria are diverse according, if you look at this picture from an OBGYN perspective and from a psychiatric perspective, and also methods of evaluation can be different. So nowadays, as reproductive endocrinologists, we really need to view at PMS or PMDD through our biopsychosocial lens in order to really capture that multidimensional approach that is needed to address this important condition in women's life. You see here the clinical heterogeneity. According to the older literature that Martin was alluding to, more than 200 symptoms have been associated with premenstrual phase, and you see that there can be physical symptoms, very common breast tenderness, headache, bloating, abdominal cramps, edema, and so on. Psychological symptoms, extremely important: irritability, anger, feeling blue, crying, emotional instability, anxiety, mood swings, poor concentration, and so on. So emotional and behavioral. And behavioral, you see insomnia, vertigo, dizziness, and so on. And so you easily understand that which one are the women that have PMS, the one that have at the same time edema, headache, irritability, anger. Very difficult to have good epidemiology, as I said. In here, you see, this is a very nice review that I selected because it put aside the definition we have as the American College of OBGYN on the left side. And of course, I know as OBGYN, we try to capture at the same time the role of affective symptoms and the role of somatic symptoms. And you see that according to criteria in OBGYN, you should demonstrate that you have a patient that is able to recall for the 3 previous menstrual cycles that during the 5 days before the menses had at least one of the affective symptoms, angry, anxiety, confusion, depression, irritability, social withdrawal, or somatic symptoms, abdominal bloating, breast tenderness, swelling, headache, joint or muscle pain, swelling of extremities, and weight gain. And then you should demonstrate as well that these women, they will feel okay for at least a significant amount of time that correspond to the follicular phase. Of course, the symptom should be there in the luteal, especially in the 4 days before the onset of menses, should not be related to any other conditions such as drugs, alcohol, or whatever, and should be relevant to women quality of life and well-being, but especially working as socially, academically, or whatever. And more importantly, you really need to document prospectively for 2 cycles of a prospective recording. You see on the right part, however, what we the psychiatrist means with premenstrual dysphoric disorder. And you easily capture that they focus, of course, their attention only on the psychological and behavioral aspects. So they are the core of the diagnosis. And you see that the criteria are slightly different. First of all, you should report to have this symptom for at least for 1 preceding year. So this is obviously a rare condition, and to be labeled with the premenstrual dysphoric disorder, it should be really important. The symptom that you have should be marked, affective lability, irritability, and so on. And you see that you can combine some of the symptoms that are really the core symptoms of the diagnosis with another set of symptoms that encompass a lot of somatic symptoms and some of the physical symptoms we have seen in the criteria of the ACOG. So the physical symptom, breast tenderness, they are ancillary to the diagnosis. It is confirmed that the woman should be impaired in social and productive and family and relational activity, but you should document prospectively as well this disorder for 2 months. And as you can imagine, this is not so easy in the office. And so this is the reason why some friends, they propose a sort of scheme in order to collect, on one hand, the basic information necessary to try to identify women they are at risk. And you see here, this is a wonderful article that was signed as first author by Petra Stutte, that Martin knows very well. And she was the one chairing the Swiss consensus that was published in Gynecological Endocrinology. And she really very elegantly summarized all the main things that we should ask. And we should really ask about menstrual history, psychological and psychiatric history, history of drug, family planning, all the things as reproductive endocrinology we do when we want to really have a picture of women's health in terms of menstrual cycle and reproductive life cycle. And also another friend in Spain, Iñaki Lete, was able to revise very recently the use of this tool that was published by Steiner several years ago. That is a very simple tool. According to this tool that is named Premenstrual Symptom Screening Tool, which can try to very easily capture if the women have all the symptoms they are listed in the DSM-5 criteria, and to try to give a rate to that. And according to a validation, we can separate those women, they have extremely severe symptoms, and so they are candidated to receive a diagnosis of PMDD, from some women, they are candidated to receive a moderate or mild diagnosis that they are more in the box of PMS. Then, of course, you can use some diaries, and I'm particularly pleased to show you this because it was a diary that was developed by Mortola the year I graduated, and then together with my dear friend, Professor Facchinetti, that when we were working together in Modena with Professor Genazzani, we validated in Italy. And you see that this is a calendar that includes 10 physical and 12 behavioral symptoms that we rate from 0 to 3. We develop a cutoff for the Italian population, but there are many validations across the world. But what we identify together, that at least in the Italian population, the two factors, they are more important. They are really the one that we have in the guideline of the American College OBGYN. So factor 1 and factor 4, you see some somatic and some emotional and behavioral symptoms. And so at the end of the day, these one are the symptoms that usually we see in the OBGYN office and in reproductive medicine. And I want to share also another very interesting review article that was published in our journal. And I was so proud when I shared this review with the one I considered the Pope in the field of studying PMS and PMDD, that is our dear friend, John Stad. Because John has devoted all his life to try to make people and gynecologists and obstetricians to understand how we should separate a depression that is related to hormone, and we named together reproductive depression. That means PMS, and postpartum depression, and menopausal depression, and Professor Genazzani will explain us about this, from psychiatric conditions such as bipolar disorder. So in this review, together we summarize tips and tricks that we can have in the history of the patient to capture this relationship between reproductive events and premenstrual syndrome. And you see that, for example, we realize that women, they have really a premenstrual depression are the one they develop also postpartum depression. They have a recurrence because these symptoms, they can change throughout the reproductive life of women. So women, they start only with a mild premenstrual syndrome, and then, let's say, following 1-2 delivery, they develop severe form of PMDD. So we really need to capture this relationship among all these aspects in medicine. They are related to what we name progesterone intolerance syndrome. This is a clinical entity that, of course, as you see in red, is related to this triad of reproductive depression, premenstrual syndrome, premenstrual dysphoric disorder, postpartum depression, and premenstrual transition-related depression. But you can see that there are other conditions and also psychiatric conditions such as anxiety, bipolar disorder, eating disorder, but many conditions in menopause that the people that work in reproductive endocrinology know very well. Sometimes are neurological conditions such as epilepsy, sometimes it's migraine, sometimes it's multiple sclerosis, but can be also autoimmune and dermatological condition, and many other symptoms. They can be exacerbated by progesterone exposure or progesterone withdrawal, and we may say as well associated estrogen withdrawal. And this is interesting to think about all these complex picture, because I know that Professor Genazzani will explain you very well that this can occur also by using exogenous progestogen. And according to the biochemical nature of exogenous progestogen, we may have some positive or negative effect on mood and behavior and several conditions in women. And I know that he will explain you a lot about the metabolism of progesterone within the brain and what we see into the circulation. But I just want to remind you of the biopsychosocial model to interpret PMS and PMDD, because a very famous psychiatrist, Stahl, several years ago, what he said, okay, there are many mechanisms they are candidated to modulate the effect of progesterone within the central nervous system, many mediators. We contribute a lot on research on the opioid system. Other group, they contribute to serotonin, dopamine, GABA, and many other mediators. But what is relevant to remember that across the menstrual cycle and across reproductive life cycle, women, they have a neuroendocrine threshold that can be modulated by several factors: age, stress, environment, nutrition, lifestyle. And this is essential because to understand that we really need to manage these symptoms with a biopsychosocial approach. So maybe throughout nutrition, throughout changing lifestyle, we can improve these symptoms. They are related to our ability to adapt to the change that estrogen and progesterone offer throughout the cycle. And we don't have to underestimate this change, because sometimes we miss very relevant disturbance for women in terms of quality of life and well-being. And on the other way around, we don't have to overestimate what is paraphysiological variation. So not every woman is hysteric. I think John Stahl explained us this very well. As I told you, a lot of groups are trying to study all the systems that can be impaired during this adaptation. And I want to remind to everybody that it is absolutely useless to measure hormones, circulating hormones, just routinely to make a diagnosis. We know that there is a group of women that have a peculiar vulnerability to normal fluctuation related to the menstrual cycle, which translate in adaptive responses. And we know that can be an impairment of the hypothalamus pituitary adrenal axis. Some group have demonstrated thyroid dysfunction, a change in melatonin rhythm, modification of the renin-angiotensin-aldosterone system, subclinical hypoglycemia. All these things are very relevant to understand the peculiar symptom in a woman. Maybe somebody, let's say, that has water retention. Of course, probably she has an impairment of the renin-aldosterone system, but that will not explain the diversity of the syndrome. So at the end of the day, dear friends, hormonal measures are not necessary for diagnosis unless we have to document some kind of menstrual dysfunction, and we want to exclude that there are some endocrinological condition underlying this action. The most important issue is the topic of neurosteroids that Professor Genazzani will address later on, and the impact that neurosteroid and on the central nervous system, in particular the GABA system. But we know that there are some vulnerable women, as I told you, and we should recognize them. And I told you we can recognize by the medical history, but there is a very strong group out there in the literature, that is Peter Smith, our friend, that was able to demonstrate that you can do a test to understand which one are the vulnerable women. And there is absolutely no doubt that these women, they are sensitive to progesterone and even to estradiol probably. Why? Because he did a very famous real experience in real life, in real women. He treated PMDD women with GnRH analog to shutting down the menstrual cyclicity, progesterone exposure, and estradiol. And he demonstrated that when you do an add-back therapy to GnRH analog, you restore and you made the woman recurring the symptomatology. As I told you, some people, and I will end my talk by sharing with you some pearls of practice to handle PMS and PMDD, that believe that by inhibiting ovulation with COC, they can obtain the same results as shutting down the system with GnRH analog that, as you know very well, you cannot do for long. But unfortunately, the outcome that we obtain with COC is controversial. And there are some data out there suggesting that it's very important, the estrogen-progesterone ratio that we use in our combined hormonal contraception, and as I said, the biomedical nature of progestin in modulating, especially PMDD. You see here that in the armamentarium, on the pharmacological armamentarium of the clinician, we have, of course, according to this double nature of the PMS and PMDD, both psychoactive agent on one end and ovulation inhibitors on the other end. And also we have signal in the literature that we can use Also, some drugs we know very well in reproductive endocrinology, for example, bromocriptine to lower prolactin, spironolactone to fight water retention, and other compounds such as danazol, etc., they can play a role. But of course, our attention as OBGYN is on COCs. And in the review article by Petra, we had all the studies that were published before 2017, and you see there are very few. And they suggest that this compound, drospirenol, levonorgestrel, norepinephrine, desogestrel, they can be chlormazepine acetate, they can be good progestogen. But I know that Professor Genazzani will show you that some maybe they are better than another. And so we really need to have more research in this context. What is true is that when you reduce the hormone-free interval and you move from 21/7 to 24/4, or even to a continuous combine, that you never stop, so you have an extended regimen, you may obtain some benefits, okay? And then, as I said, however, many women, they treat this condition as paraphysiologic, and also doctors that believe that it's not worth taking a drug to handle this condition. Maybe women that don't want to take a combined hormonal contraception and so on. And so we know that some non-pharmacological approaches, such as particular diet, such as high intake of carbohydrates, low intake of proteins before menstruation, or doing a lot of physical activity, aerobic in particular, but also using phytotherapy. And we have some data out there on chasteberry, saffron, evening primrose, etc. We have diet supplement, and we publish a randomized placebo-controlled trial with Professor Genazzani, my first paper, magnesium pedolate, very important, but there is also a trial on calcium carbonate, and there are many data on cognitive behavioral therapy for 3 months, at least 1 time a week. What I have to remember to everybody, that placebo has a nice eye effect, as in any psychosomatic condition. This placebo doesn't last long. So if we want to produce very good randomized placebo-controlled trial with supplements, that is a very important point of our research nowadays, also in reproductive medicine, we really need to go on at least for 6 months, something that is not so easy. The future is really in the concept that Professor Genazzani will explain to you, because nowadays we have drugs, they are out there to change the history of this kind of neurobiology of reproduction, because there are a lot of steroids with neuroactive properties as drug that is under development. We have already brexanolone for postpartum depression, and we hope we will have soon in randomized phase 3 A/B clinical trial with sepranolone, that is a neuroactive steroid that is a very potent metabolite of progesterone. And you see that on this very important receptor, that this is GABA, we have some nutraceutical that can act, because you recognize here magnesium and vitamin B. They are so important for the functioning of this receptor. And you see, of course, progesterone, as Andrea will show you, is essential for a good functioning. And I want to finish with the scheme of my dear friend Petra, that say, okay, women with premenstrual dysphoric disorder can be seen by the general practitioner, the general gynecologist. He has to recognize this condition, maybe with a screener. And then, of course, we really need to educate women to recognize their symptoms, to collect in a diary. And then, of course, we really need to send to the gynecological endocrinology specialist. It's very rare that we propose hysterectomy and oophorectomy to women. It's really, really rare condition in which we do that. Of course, we can handle also with alternative medicine. And we should follow an algorithm that essentially follow the intensity of the condition. So recognition and education, First line with nutraceutical and of course COC. If there is a strong psychiatric component such as PMDD, we send to the psychiatrist or we handle with antidepressant. And in very rare case, we can shut down the axis with GnRH analog, add back therapy, or even propose oophorectomy. And with this, I thank you very much, and I invite you all in Florence if we can go there all together. Otherwise, we will meet virtually another time. Thanks a lot for your attention.
Thank you, Rossella. It was an excellent lecture, state of the art, as it has to be, practical and in theory, absolutely correct.
Thank you.
We pass now directly to the next lecture because of the time we had to spend at the beginning for technical problems. I will say already now that we add the last minutes at the end to allow the questions. The next lecture will be presented by Professor Genazzani. I don't need to introduce him, everybody knows him well. And he will speak about the menopausal aspects of mood and hormones. Andrea, please.
Thank you. Thank you very much. And I will try to go more on some basic aspects concerning the effect of hormones and mood, starting by, starting by the concept that, okay, you know, we have to start speaking about what can happen in the menopause. What are the symptoms of the menopause? If you go to see what are the climacteric symptoms, you can see that hot flashes, they are touching the brain, vulvovaginal atrophy, no. Sexual dysfunction is also touching both a center of the brain and the periphery, but the other major symptoms are mood swings and anxiety. Then you can see that the bigger part of the symptom of the menopause, they originate inside the brain. And what are the central nervous system common? The vasomotor, but also the sleep disruption. You have seen depression and anxiety, cognitive changes, and migraine. And you see also that speaking about the vasomotor symptoms and sleep disruption, they are associated to very typical basic aspects of something will happen in the brain, increasing noradrenaline, reduction of dopamine and serotonin, increasing peripheral effect of dynorphin, dyspeptin, and cortisol. But also, if you look what happened concerning the mood, possible mood changes, you have to reflect with me that the increase in noradrenaline, the reduction in dopamine, serotonin, typical of the postmenopause, but also the reduced GABAergic function, the reduced beta endorphin, and the reduced brain content of allopregnanolone and the dihydroepiandrosterone, together with the increase of cortisol, are all of them are typical events who characterize also depression and mood disorder as basic diseases of the individual. Then, during menopause, happen more or less in all women some central changes of substances and factors and neurosteroids who are typical also of the diagnosis of mood disorder. When we speak about what are the steroid intracerebral level, you have to reflect that this depends certainly from the input from the peripheral glands, such as the ovary, the adrenal, the placenta during pregnancy, but also you have to remind that the brain have a very potent capacity to steroid produce and metabolize in the brain. The brain is a steroidosynthetic organ, as the adrenal, as the ovary. Only the brain cannot move to the production of cortisol and cannot have any specific proteic hormones who stimulate the steroidogenesis. As you know, LH stimulating the ovary and in the testes, ACTH stimulating the adrenal. The brain do directly its steroids. And the production of the steroids is only dependent by the expression of the steroidogenetic enzymes and steroidometabolizing enzymes responsible to modify the steroid synthesis. Then it's only the activation, the local activation of the DNA and RNA messenger leading to these enzymes who is responsible to the different concentration of steroid in the brain. But when we reflect, why steroids are so important? Look in that slide. The steroids have a profound mechanism by which they impact the central nervous system. They have an organizational activity. You know that the brain is sexually dimorphic. We have a female brain and a male brain, but we started all with a female brain. Only the prenatal testosterone increase in an individual who have receptor for androgen modify the structure of the brain and change the male brain to a female brain. Later on, steroids have an activational activity. Steroid can interfere in neurotransmitter function in the receptor subtype cross-talk. They can induce the receptor. They have also genomic and membrane effect. They touch the oxidative metabolism and they can modulate the apoptosis. They have a series of cellular effects on neuron and glia. They can stimulate the production of synapses. They can control inflammation. And I remind you that they have a very profound neurovascular effect. 1/3 of the brain mass is done by vessels. And concerning the non-reproductive central function impacted by sex steroid, they can touch not reproductive events, the affective state, then mood, sleep, libido, sexuality, social behavior. They touch motor coordination, neuronal excitability, pain threshold, auditory threshold. They have a very profound effect in cognitive function, and they have by multiple mechanisms important effect on neuroprotection. This brings to what? This brings that we have two brains, one male brain, one female brain, which was the dominating. They have different sex, different expression of receptor and polymorphism, different neuronal subpopulation in the various brain areas. And this lead that Rossella and I, we have two sexual orientation, a gender identity, we have a cognitive dimorphism, we are differently sensitive to the hormone therapy, and we have a different prevalence of neurological and psychiatric disease between men and women. Then I would like to introduce you to that concept of brain vulnerability. What happened at the menopause? In menopause, we have a sex steroid withdrawal. Women lose estrogen, lose also the important changes of progesterone. I remind you that adrenal progesterone brings to 200, 300 picograms of circulating progesterone, while gonadal ovarian progesterone bring progesterone to 10, 15, 20 nanogram per milliliter. And during pregnancy, the placenta toward several decades of nanogram per milliliter. And then the mechanism by which the menopause can touch is because after menopause, you have a reduction of CRF, you have a reduction of production of propiomelanocortin-related peptides and of vasopressin. You totally change the central noradrenergic, dopaminergic, serotoninergic, and acetylcholinergic system, and you strongly reduces allopregnanolone and GABA. And what are the signs and symptoms? The signs and symptoms, they should be irritability, anxiety, fear, depression, fatigue, psychosis, but also decreases seizure threshold, and the most simple one, the hot flashes and autonomic hyperactivity. But I would like to show you an experimental data. I was telling you that the brain is sensitive in its capacity to metabolize steroids. This is a simple experiment. What happened in the hippocampus and in the hypothalamus in rodents. Fertile rodents, these are the concentration of allopregnanolone. You can see on the left of the figure, you can see in the column, orange column, are the allopregnanolone concentration in the hippocampus and the hypothalamus in the fertile animal. You castrate the animal and you see in gray how allopregnanolone is going down. not because it's originating from the gonads, but because in that level, the reduction of gonadal steroids modify the capacity to produce, locally produce allopregnanolone from locally produced progesterone. And this event, you look in pink, is absolutely the same what happened in the aging process. But is this phenomenon related to the aging, or is this phenomenon related to the lack of some of gonadal steroids? Please look what happened by the administration in green of conjugated equine estrogen to ovarectomized rats in gray. You can see how the conjugated equine estrogen, they strongly induce and activate the local production from progesterone to allopregnanolone. And this is not only in the younger animal. You see in yellow how in older animal, the older brain, stimulated by estrogen, profoundly increase a local production of allopregnanolone. That means increases the 5-alpha reductase activity, which is the enzyme responsible for the progesterone, from progesterone to allopregnanolone biosynthesis. And then now you remember Rossella have spoken about the progesterone effect. What there should be in the brain, the progestogens effect? You know, the progestogens are not only progesterone. Many substances, they can have progestogenic effect because they stimulate the endometrial progesterone receptor activated by estrogen therapy. But progestogen, they can have also a progestogenic effect, an androgenic effect, an estrogenic effect. They can interact with glucocorticoid receptor and mineralocorticoid receptor. And they can interfere in the neurosteroid synthesis. While all the studies which have bring to the clinical development of these substances have only evaluated the uterine effect. I want to show you now one beautiful slide produced by Thomas Rabe 20 years ago. You can see here how the different progestogen can have a very potent inhibitory effect on 5-alpha reductase. You can see by comparison the finasteride, which is the most powerful 5-alpha reductase inhibitor effect. You can see how all the different progestogen, they can have different and important activity in the reduction, in the inhibition on 5-alpha reductase. This brings that these substances in the brain of sensitive individual, they can reduce the endogenous allopregnanolone production. And now, speaking about menopause and what changes in mood, I would like to put your attention on another area. Menopause is an event who happen around your 50s, but it's something which have, concerning the circulating steroid, which already have started very important changes. In that slide, you can see in green the circulating concentration in men and in yellow in women of the hydroepiandrosterone sulfate. And in the right panel, the changes of circulating cortisol in the two genders. You can see, originating from the same gland, from the adrenal gland, always under the control of the same hormone, ACTH, which is regulated by the hypothalamic CRF, we have that completely different trend of the hydroepiandrosterone sulfate, who progressively decline during all the life, and having the highest concentration at our 20s, it go down progressively while circulating cortisol progressively increase. And this is not only for circulating delta-5 androgens, but this is free testosterone. I want to show you the data from Davison. He most clearly demonstrates that circulating free testosterone have the highest concentration in the young time and then progressively decline stronger during fertile life and reaching the lower concentration in elderly population. But the biggest reduction is not after menopause and linked to menopause. It's linked to important changes during already fertile life. And if you put together all this one, you can see that a premenopausal woman, 40 years, she have already lost 50% of all total androgen, and at 70, 80%. And this bring also that that time of the life. It's beautiful. I would like to show you that slide from Roberta Brinton. She will be with us next week in a GREM webinar. And in that slide, she showed that in perimenopause, only 20% of the individual are asymptomatic, but 80% of symptomatic. Hot flashes, they have no hot flashes, only 30%, but 70% have hot flashes, and some with cognitive dysfunction, some with cognitive dysfunction, insomnia and mood changes, some with insomnia or insomnia and mood changes, insomnia and suicidal ideation, insomnia, depression and mood changes. Some have hot flashes and depression, depression and mood changes, and suicidal ideation, or only mood changes. You can see here how it's rich of symptoms, that perimenopausal transition. And I would like to go on that slide from Bromberger to 2011, who show that major depressive disorder increases in peri and postmenopausal stage. In women, we had previous major depressive disorder. Then the woman who have already previous major depressive disorder, she is even more vulnerable after the menopause. And this one from Brown in 2008, they show that the experience of perimenopause depressive symptom may be explained by vasomotor and other menopausal symptoms, such as irritability and anxiety, more hot flashes, more irritability, more symptoms of depression. But also another one, beautifully Rocca in 2008 showed that in young 45 years, ovariectomized women, in comparison to the reference population, they have an increased incidence either of depressive as well of anxiety disorder. Then in another side, menopause hormone therapy, there are evidence that estrogen therapy enhance mood and improve well-being in non-depressed perimenopausal women. But beautifully, in that study, the KEEP study, Kronos Early Estrogen Prevention Study, they have shown where they have made the comparison between the administration of cyclic transdermal estradiol 50 microgram patch or conjugated equinestrogen 0.45 milligram plus micronized progesterone 12 days per month, so 200 milligram. And after 4 years of treatment, CEE, but not transdermal estradiol, improve anxiety and depression effects not seen after only 2 years. Then also the time of exposure is important. But you know, estrogen-based therapies might augment clinical response to antidepressant in individuals who were already taking serotonin or noradrenaline reuptake inhibitors in perimenopausal with vasomotor symptoms. That already individual under antidepressant, they are improved by the administration of hormone therapy. And in the beautiful study from Joffe, in already individual, it was an open trial who showed benefit of mirtazapine for major depressive disorders in peri and postmenopausal women. And you can see that only with estrogen receptor, 100% have remission, while with estrogen plus progesterone, only 81%. Pauline Mackey, which is a leader in that area, she was telling that transdermal estradiol with intermittent micronized progesterone may prevent the onset of depressive symptoms in euthymic perimenopausal women. But the evidence is not sufficient to recommend estrogen-based therapies only for preventing depression in asymptomatic women. And in that other study, the group of Rubinoff and Peter Schmidt, they have shown that menopausal hormone therapy was able to reduce in euthymic perimenopausal and early postmenopausal women, was easy to take the score of studying depression scale. Then the administration of transdermal estradiol plus micronized progesterone is able to reduce the effect on this one. But now I would like to conclude this talk on another area. I remind you that if you go on this steroidogenesis, you have to remind that the hydroepiandrosterone in equilibrium with DHEA sulfate is responsible for androstenedione and then by aromatization estrone, and testosterone and by aromatization estradiol production. Then DHEA is able to produce androgen and estrogen. But if women, until the moment when they have the ovary, in that beautiful slide from Fernand Labrie, is able to produce steroids from the ovary, these are responsible for circulating steroids. But after menopause, from where they are coming, the circulating estrogen and androgens? Only from DHEA. Is circulating DHEA, which can be metabolized at periphery and can offer the possibility to be transformed in a more potent androgen or in an estrogen. Is DHEA. And when we speak about female sexual function, I would like to remind you by the slide from Susan Davis that DHEA sulfate is the only androgen who have a positive profile in female sexual function domain related to at the different age, either in younger and less younger women, a positive correlation between female sexual function domain and DHEA sulfate circulating level, not so much androstenedione and testosterone. And now, in last 20 years, we have published a huge series of papers with our staff showing that if you administer to a postmenopausal women DHEA at various levels, independently from the androgen changes, but please look how estradiol increase, but look also that progesterone increase. And progesterone cannot be produced by DHEA. This indicates that DHEA administration modifies the intraadrenal synthesis of steroids and increases progesterone production. But DHEA also increases allopregnanolone, reduces cortisol, and increases beta-endorphin. But what is the characteristic of depression? To have low beta-endorphin, high cortisol, low allopregnanolone. And what DHEA is doing? DHEA, which is normally going down during all the life, DHEA administered improve again progesterone and allopregnanolone, improve circulating beta-endorphin, and reduces cortisol. And in addition, a beautiful study from Bendor-Rivka from the group of Peter Schmidt, they show that DHEA can also stimulate the androsterone production. And androsterone production, this both in men and in women, and androsterone production have a potent antidepressive mechanism. And also, only DHEA given as an only therapy to postmenopausal women, you can see also with a small dose, gave the same positive effect on sexuality total score as HRT or Tibolone, and the sexual intercourse total score as HRT and Tibolone, and not modify the relationship total score. Then to conclude, dear friend, when we speak about of menopause, we have to think also to the adrenopause, which is at the same time strongly affecting circulating central, peripheral, and central steroids. And both of them, they are a cause of frailty, of vulnerability, of diseases, of changes in lifestyle. And then we have to think to a new concept about menopause, aging, and menopause hormone therapy. We have to rewrite the dynamics of aging processes as we are living so longer. In comparison to the past, we have to think about to maintain steroids in general means to maintain the course of nature. Changing is different than aging. We have to preserve the individual. And until now, no data indicated in women who well tolerate menopause hormone therapy. We have to stop it only for the duration time of the exposure. Absolutely none of them. Then, dear friends, I hope that I have bring to you a series of data showing how the brain is fantastically sensitive to circulating steroid, that when we speak about the circulating steroid, sexual steroid, we have to remind that in addition to the gonads, also the adrenal is a fundamental organ who provide a huge amount of molecules who can be metabolized and transformed in your bodies. Thank you very much.
Thank you, Andrea. A real firework. And I think we should repeat your lecture for psychiatrists. They don't know about it. Now we are coming to the questions. And I will repeat some questions that Rossella did already answer privately because they might interest other participants too. One is the dosage of magnesium. Could you please answer to that to everybody?
Yeah, you know, the study was produced with the pedolate magnesium, and as I show in the slide, that the people that can see is 360 for 3 times a day, because we should remember that magnesium should reach a specific threshold to enter the neurons and to do the job as to do. And so we should select bioavailable magnesium, such as pedolate, bisglycinate magnesium, citrate magnesium, and so on. Otherwise, is useless. So you really need to have a certain dose that is able to enter the neurons.
And the next question of general interest is about the SSRIs. What do you recommend?
You know, the data, the best data you have seen, I underline some of the psychoactive agent in my talk were collected several years ago with fluoxetine and with paroxetine. Even venlafaxine is doing some good job. The most important thing is usually when we deal with PMS and PMDD, we do a temporary treatment. So psychiatrists prefer to have a drug with a short-acting half-life in order to avoid a continuous treatment, but to do just for the 2 weeks is needed. But we should work more with our colleague. As you said very well, we should repeat this for psychiatrists, especially the lesson of Andrea, because it's very hard to find psychiatrists like Peter Smith. You know, we don't have so many across the world. And this is the reason why it's so difficult to produce very good data, because as a OBGYN, I don't feel so comfortable in handling psychoactive agent. You know, we should do, but as you know, we really need to be careful, because we really need to avoid to treat the women that maybe they have a suicidal behavior, they may have a bipolar disorder, and this is the reason why John Studd tried to teach us so much, but it's always difficult to use drug in the armamentarium of somebody else. So I very much look forward to neuroendocrine drug that can help us, because it's more in our hands, it's more in the hands of reproductive endocrinology.
Thank you. And I think you have to repeat here what you said already, that the most dangerous form of PMDD is suicidal thoughts. Yeah. And most psychiatrists don't know that the most efficient treatment for that is suppression by a Genazzani analog with the add back. You can do this treatment for years, and patients are really well with it, and they have less side effects than with antidepressants.
Yeah, you're absolutely right. This is the seminal work that some people did, and yeah, it's essential to understand that.
Thank you. Now I have a question from Sergio Brantes. You answered it already privately. What is the best cock you can use for treatment of premenstrual syndrome?
I think I would like to have also Andrea comment on this, because, you know, we produce, there are some data out there suggesting that probably drospirenone, especially 24/4, is the best showing, the best evidence we have that you can do some benefits. But as you know, these data have been in some way sometimes also criticized, because they said it's not in a huge sample of women, the data they collected. You know, I think extended regimen is very important. And according to the sensitivity of the brain to the metabolism of the progestogen, this is the issue. So you should try to use a dose of estrogen that is enough, because some women that feel depression because they have low estrogen available in the brain. And on the other hand, they feel the break of the pill, so it's better to take 24/4 or extended. And there are some women, they are vulnerable to some progestogen, let's say even levonorgestrel, because I think Andrea can explain you better. This concept is a question of steroidogenesis in the brain.
Thank you. Andrea, what do you think
Yes,
about
I
it?
would like to follow Rossella, and thank you. I have shown, you have seen the slide that I have shown on the effect of different gestogen on 5-alpha reductase inhibition. And this is an experiment done in an experimental model. But if you believe that the women have so huge variability, you can have a more vulnerable individual to one or to the other. And then once that a woman, she develops depressive symptoms under any kind of contraceptive, we have immediately to change it, to move on with another progesterone. I remind you that drospirenone have no effect on allopregnanolone metabolism, and also I have to remind you that another one is chlormazepine acetate, which is important in that way. But I would like to add something more to what Rossella was telling us. It's important in my perception, the continuous treatment. You don't need to stop. You can stop every 3-4 months the treatment just for 3-4 days and then to start again. And in some individuals, they need, as she was exactly telling us, she needs to potentiate the circulating total estrogen. This not only going to rising the amount from 20 to 30 nanogram of 18 estradiol, but giving them some amount of transdermal estrogen. You can increase in this individual giving 0.5 milligram or 1 milligram a day of transcutaneous gel containing estradiol, and this strongly potentiate using a progestogen who don't interfere with allopregnanolone production.
Thank you. In the study of Römer, MPA has not been presented because he was speaking about pill. But what are you thinking about MPA in depressive women? I think it's a contraindication. Andrea, and then
yes,
Rossella.
yes, you know, medroxyprogesterone acetate is a glucocorticoid. A glucocorticoid will interfere also with progesterone receptor in unwell exposed uterine endometrium to estrogen, but it's a glucocorticoid, interfere with the glucocorticoid system, and also inside to the brain, have a very specific activity. I would like to go back to what God or nature have decided for women. They have decided progesterone. More similar are the molecule to native progesterone, better it is in menopause hormone therapy, progesterone or dihydrogesterone, which is only a small modification of progesterone molecule. These are the progesterone needed. And orally, sometimes dihydrogesterone. I remind you that if you give oral natural progesterone, you strongly increase the circulating allopregnanolone. You have to give only during the night time, not during the daytime. But for progesterone, you can give that by vagina. By vagina is beautifully absorbed, 100 or 200 milligram of progesterone. They give a beautiful protection for the endometrium.
Thank you. Rossella, would you like to add something?
You know, I really think that, of course, you may use even medroxyprogesterone acetate if you need for some purpose, but it's not the best progestogen to me because it will significantly stimulate the glucocorticoid receptor. And we know that if we increase the vulnerability to stress, to the effect of stress hormone, we increase premenstrual syndrome and even depression. Of course, you may have some women that do not develop depression under medroxyprogesterone acetate. You really need to understand that is an individual threshold of vulnerability, as I have tried to explain to you. And so it's only the clinical experience you have with your patient, the medical history, and following the woman throughout the course of the disease that really will help you to select the best. But on, based on data, progesterone or retroprogesterone, they are the best one.
Thank you. Now we pass to the questions addressed to Professor Genazzani. The first one from Mandy Leonhardt. What do you think about pregnenolone replacement?
Yes, it's okay. Until now, we have not sufficient experience on pregnenolone replacement. There are a series of studies with pregnenolone-like molecules, which will be very soon available on the market for specific indication. But still, I don't have any specific study on that one. Certainly for the brain, pregnenolone, but allopregnenolone is the most important steroid for its effect on GABAergic system, because you have to remind that mood and mood disorders are very sensitive to GABAergic receptor stimulation, and on that one, allopregnanolone is the key molecule.
Thank you. The next questions come from Galina Lesko. Thank you very much for the very useful lecture. How long can DHA be taken for menopausal women? What risks can be associated with DHEA?
Okay, then concerning DHEA, we have not seen any possible eventual risk. In our experience, we have published data until 2 years of continuous treatment. We have known patients who are taking it since 15 years, and we have apparently no evidence of any possible, because the total amount of peripheral metabolites is dependent from the exposure, and then you have to reduce going on with the time. You have to modulate the treatment from circulating level of DHEA sulfate, which is the most easier parameter to be assessed. Once the DHEA sulfate reaches the concentration above 2.5 microgram per milliliter, you have to reduce the daily amount. This is for women, but also for men. And you have to remind that also aging process touch also the men. And also I have experience of most men also who take not so much testosterone, but take DHEA. And by the DHEA, they also increase, touch also circulating level of testosterone too.
Thank you. And the next questions comes from Cartagena. Alvaro Monteros did ask it.
Hola.
Greetings, Rossella and Andrea from Cartagena, Colombia. I have to add a pity that the Congress had to be postponed, but we will be there next year. The impact of retroprogesterone is different from micronized progesterone in the central nervous system and premenstrual syndrome. What do you think of it?
Concerning the impact of dihydrogesterone in the brain, we have not seen any, by that structure, you cannot find any changes in circulating progesterone giving DHEA, giving dihydrogesterone, because the system that we use to measure progesterone is not sensitive to dihydrogesterone. And then I cannot tell you, but giving DHEA, we have made some studies in animals, giving DHEA, and giving DHEA, we have seen also that we have a positive effect on central beta endorphin, although you have seen all the studies that we have seen on central beta endorphin. And I can tell you that the administration of progesterone make easier to evaluation of the clinical metabolites in comparison to the other one.
Rossella, would you like to add
Yeah,
something?
if I may add, Alvaro, there are no very good data suggesting that progesterone can be used as a treatment for premenstrual disorders, So I don't think we will have so many difference between progesterone and dihydroprogesterone, and according to the literature I revised. And maybe we should study more the effect of the HEA on premenstrual symptoms. I have a cohort of women, they are treated with DHEA. I never published that. And especially if they have a low mood and low libido, they can significantly improve. Whereas I noted that when they have a lot of irritability, insomnia, anxiety, the results are less consistent, and this is the other point, the heterogeneity of the syndrome. So we should really focus on the symptom specific impacting on that particular woman, and maybe we need a bouquet of treatments to really handle all the diversity of syndrome in women.
Thank you. Then we have a question from Mariana Bignarti, who would like to know if there is a polymorphism known to show a high risk for PMDD.
There are a couple of studies I recently revised in which they suggest that there are some polymorphism both on the GABA receptor and one of the subclass of the serotonin receptor. Sorry, I don't remember which one is, suggesting that there is a link between this polymorphism and more vulnerability. But as you know, this study, they are always in the infancy because they cost very much. It's very difficult to select the population, but for sure, I'm sure that we will demonstrate that there is a genetic disposition.
Thank you. And the practical question, is it safer to use DHEAS than estrogen in patients with thrombotic risks? The question is coming from Mayela Dekas.
Yes, we have evaluated the coagulating profile under DHA treatment, and we have not found any significant changes about the treatment, even though this can increase circulating estradiol. But you know, it increases circulating estradiol because it's metabolized towards estradiol, and this is not, and this is something will happen in the body, but don't touch the liver coming from the porta vein. You know, is the estrogen, the oral estrogen administration would modify the liver protein synthesis, not so much the circulating amount of estrogens.
Thank you. And two questions from Luciana Pistelli. The first, to enhance GABA natural progesterone effect by oral transdermal route are the same, meaning are both of the same efficiency, transdermal and oral.
Transdermal and oral estrogen
the question is about GABA natural progesterone effect by oral transdermal route.
Okay, we don't have any study showing evaluating this different approach by the administration of progesterone transdermally, or also the administration of progesterone, you know, the administration of progesterone per vaginam and the administration of progesterone per oral. Administration of the oral progesterone is strongly activated by a huge metabolization inside to the liver. Then you have huge amount of allopregnanolone immediately starting. And then this can touch in the sensitive patients and can modify also the vigilance, can affect some, not so much the mood, but mostly the behavior. And we have also some risk to be sleepy, a sleepy treatment. So this is the reason why we don't give progesterone in the morning, we give only in the night. Giving by per vaginam also, this don't touch the intra-liver metabolization of progesterone to allopregnanolone. And then this is associated to a different increase of circulating allopregnanolone with the same amount of progesterone in comparison to the oral administration, and have less evident effect concerning the GABAergic system.
And linked to that, and that goes to Rossella, because DHEA and S enhance allopregnanolone, do you think it would be good for premenstrual syndrome too?
Yeah, I commented before without knowing that was asked. I mean, we can use, but there are not very good data published out there. And as I said, you know, there is a very diverse response in patient, probably according to the metabolization.
Thank you. And staying with oral versus transdermal, in the slides you have shown, Andrea, there is an apparent contradiction. Polymachy recommends transdermal estradiol for depressive patients, and the KEEP trial has shown that CEA orally is better. That seems a bit strange. Do you have a comment to that?
Yeah, the comment is the dose. When John Studd was using transdermal estradiol, he was suggesting patches of at least 100 micrograms of estradiol, not the 50 micrograms. In the KEEP study, they have used 50 micrograms. And 50 micrograms give a circulating concentration of estradiol rising only a few picograms. You have with 50 micrograms circulating level of estradiol around 35 and 40, while with 100 you have 78. And then I think this is the dose of circulating estrogen who can have an effect. You know, the brain is not so much sensitive to minute modulation, minute changes of estradiol, but to chronic, a more important exposure or less important exposure.
Thank you. Rossella, would you like to add something?
No, not to this. You know, I realize that a very important point I miss is to make a comment on the intrauterine use of a progestin, levonorgestrel. And I think this is an important point because, as you know, both John Stad and Nick Panay suggest that in these women they have progesterone intolerance, or in women they have side effects with a combined hormonal contraception or with a POP. We can propose the use of, let's say, the study was done with Mirena, but we can use also low dose IUC, and to see if these women, they are progesterone intolerant, they can do better. And the data they are suggesting that it can be the case. So when we have to prescribe a progestogen, we have always to keep in mind that we have this option that can be very useful.
Thank you. Just to add, I think Pauline Macchi is absolutely right if she recommends transdermal estrogens. There are many other benefits of transdermal way, and there are many studies showing that for depressive patients after menopause, transdermal E2 is better. So I have to stay with that. And what you said, Andrea, was very important.
Yes, I agree. I totally agree. I am, if possibly, I am using transdermal and transcutaneous treatment. In my view, I prefer the gel because the gel provides a circulating estradiol concentration. Probably is less stable than with a patch, absolutely. But it provides this oscillating concentration, also reaching some higher concentration in comparison to the patch. And also, you know, I am living in a summer region, and then the patches during the summertime, some of them, they touch, they can give irritation. The people want to go now facing the sea shore, and they prefer the gel.
Pity we cannot join you. I think we have to stop here. There are some other questions left, but I think that you will answer them privately after the end of the conference. And I just cite the last question. In fact, it was not a question, a comment from Miriam Torres. Very good conference, thanks. And I would like to recommend the next webinar. The slide will appear soon. It is about menopause and obesity. I pass again to David, and he will end the conference. Thank you all for assisting, and I would like to see you, and I'm convinced that I will see you in December at Florence. Thank you, and goodbye.
Thank you very much, ladies and gentlemen. Sorry for the technical problems we had today. I remind you that if you were not able to follow the beginning of this webinar, it will be available online on the Society and on the Congress website within 24 hours. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye to everybody.
Bye-bye.
Bye-bye. And good holidays.
Ciao.
Ciao, ciao, Dolce.